The next conversation to get started, if Jonathan Bell would speak next from his heart. I also want to recognize he's here with a number of other individuals who I'm so pleased came from our PAINS group, which is a patient-powered research network that the Center for Practical Bioethics has been supporting. They are a fantastic group. We've got folks over here and folks over here. So thank you for coming. Jonathan, I'm sure, appreciates your support, but we're going to ask Jonathan to talk a bit. I'm going to give him one of the framing questions I asked everybody, which is, as researchers, we always worry about the representativeness of our patients. You know, do we have one of everything? Can we really extrapolate? And we all know that the individual experience can't be extrapolated. Each person, each dad, each grandparent is a unique and special case. So we also recognize Jonathan can't speak for all patients, nor can any clinician speak for all doctors. But my question is, you are an expert at being Jonathan. You're an expert at your experience. And my question was, speaking as an expert, what would you say is the most misunderstood aspect of who you are and the biggest problems you've faced as a patient receiving care in a healthcare system?
To answer that question, I would say...
Sorry, I also sort of jumped in to introduce him, but I want to give you a chance, certainly, Jonathan, to introduce yourself too. Thank you.
My name is Jonathan Bell, and I suffer from sickle cell anemia, chronic illness. Okay. All right. I'm Jonathan Bell, and I suffer from sickle cell anemia, which is a chronic disease, chronic illness, chronic pain. And I've had it all my life. I mean, it's something that's hereditary. It's not something that you catch later on. It's something that you learn to live with, to deal with. And 5 other members of my family also have it. I have a deceased brother named Andrew that passed away with it. And one of your questions was one of the problems that I see is the fact that we don't have a voice in our care. And if I can, I'll just give a little demonstration. 36-year-old black male comes into the hospital suffering from chronic chest pains. He's admitted to the ER. Within 3 hours later, something goes wrong. He's admitted to the ICU. Within another 2 hours, he's in intensive care. By the time 8 hours has gone by, he's coded out code blue 3 times. Finally, they call the family. We don't know what to do. What do you guys want to do? You need to make a decision. Finally, the decision is made. There's nothing we can do. Andrew's no longer here. But one of the staff found out who I was. I was the president over the sickle cell patients down at Trump Medical Center, which I shouldn't have said the facility, but I did. And they tell me, well, if we'd have known who you was and who he was, we probably could have did something different. But Andrew's no longer here. He leaves a cherished memory, a wife and 2 kids, young kids. So what do you do, you know? I mean, I've suffered so many different things behind care that wasn't given in the right way, because you're having a bad day as my care provider, but your bad day can give me a bad who knows how long. I used to be a union contractor. I no longer hold that position because one of my nurses, in a rush to take her lunch break, decides to give me some medication and I almost lose 2 fingers behind it. That wasn't the end of the story. The next hospital stay, I come in, I get an IV in the foot that goes bad. Not 1, not 2, but 3. I beg them to take them out. They don't take them out. They say I'm a hard stick. I'm a sickler. I'm a sickle cell patient. I've been dealing with that since '98. Can you imagine dealing with something for 15, 16 years because somebody had a bad day? Because somebody said, okay, I can't stop what I'm doing to go take care of this person. So your other question, what would I like to see different? That's something that I would like to see is, you know, not being just a number or just another patient, but someone that this could be my father. I am a grandfather. I have one grandchild and one will on the way in June. I have 2 children, one in college, one that just, well, she's about to graduate as in the healthcare position. So, you know, I mean, you don't know your patient, and that's one thing that we used to say when we were as sickle cell patients. We did pretty much the same thing at Truman. We would have the nurses and doctors and everybody come in and ask us questions, and we would answer the questions. And what we used to tell them, yes, a good doctor knows his patient, but a great doctor gets to know his patient or her patient. And if you get to know me outside of the hospital, yeah, you're gonna see me probably at my worst. And I'm probably gonna say some things, I'm probably gonna do some things that you don't like, but don't hold that against me. Don't use that to form your opinion. See me when I'm my regular, see me when I'm myself, when I can talk and speak and do everything that I need to do. And then that way, if I do anything wrong, maybe I can apologize for it, or maybe I can, you know, articulate differently than when I'm in the brunt of pain, because pain is something that we all deal with differently. And I don't know anybody that likes to be in pain. But one of the bad misconceptions of sickle cell is that we are drug seekers. We're looking for the drug. We're looking for the high. And that's not the case. I don't know any sickle cell patient that has went to the hospital and said, give me this specific drug. Most of the drugs that we were given was because this worked for this particular group or this disease, so try this. And we tried it, and it either worked or it didn't work.
Thanks, Jonathan. We're going to keep the conversation going. So, Nick, I'd like to ask you the next question. I'll let you introduce yourself too. But we've heard from Jonathan a very compelling story of the lack of his family's ability to advocate for his brother, both by timing and by attention, not feeling heard in that system, not being able to be part of the decision-making process. I'd like to ask Nick, also from the perspectives that he'll share with you in terms of why he's at this in this panel, that can you give us an example where someone in your world, a family member, a nurse, a physician, a case manager, neighbor, a spouse, a partner, anyone, stepped up to support your health needs, especially during a time when you might not have been able to do it effectively yourself? And if you could share that personal story, how did their advocacy for you impact your care and your experience?
Yes. Well, I am Nick Haines, and I am a television news host and executive producer of news programs at KCPT Public Television. And by the way, every single member of KCPT this afternoon is doing a staff bowling session. And I said, no, I was going to a pain panel. And I think I got the better end of the stick. Don't you agree? I do. Thank you very much. But just my story is this, and I'm going to get to the answer to the question that comes out of this. But since the year 2000, started suffering from huge chronic headaches to the point that I would be throwing up almost every single day. And I remember when Google came to town, I'll cut the story short, when Google came to town, because people view me as the person who has a smile on my face constantly. And you started this whole session by saying, who is the grandparent, who is the person? Because you'll never know who is the person in pain, because people would not know this about me. And I have not shared this story. So you're the few people who do know it. But I probably for 10 years been throwing up almost every single day of my life. And because of chronic pain and very little treatment for it. And I remember the day that Google came to town, and the mayor of Wyandotte County, just after that, asked me to moderate a major panel in Wyandotte County with about 1,000 people. I moderated these panels. It was in the morning. I came to KCPT just to get a Diet Coke so I could throw it up in the morning before going to the session because the headaches were so huge. Go to the session, moderate this panel. They had a break in the session. I go to the restrooms at the venue at the Reardon Center in Wyandotte County to throw up, to then continue with the session. That's how bad it was. I would do a week in review program, which we tape on a Friday morning, and we runs 7:30 on Friday nights. And I would have a trash can on set. That's how bad it would be because I would be throwing up that much. I had a doctor, though, who refused to say those were migraine headaches because migraines were a diagnosis of last resort. So I couldn't get the medications that I wanted in that whole period of time. It was only my wife in 2011, having gone through getting CAT scans, all of this type of medical procedures I'm not going to go into, who then said, let's go into an allergist, can you have allergies? It was my dogged determination, and it's always the wife, isn't it, with men? Always the wife who does this, and who put me on a medication that had made a difference. So it was the wife who sort of stepped in to have a controlling influence. But over 10 years of huge pain, never really taken seriously, but also doctors who, by and large, have no time to deal with pain is such a fuzzy area. You know, that is just a complicated area where they have no time to necessarily deal with it, and there isn't masses of money to be made in the interventions. There's no huge surgical procedures where you can make huge amounts of money on it. So if you say you need a CAT scan, they'll do a CAT scan for you. If, it's what you tell them. And, I think I have this. They'll give you that. That was about it. They were doing nothing of their own volition.
Thank you, Nick. My next question is to Joy. Thank you for sharing your story of your father-in-law. And I want to know from you, and I'm sure the group would be benefited from hearing your opinion about what a higher, if not highest, performing health system potentially would look like for you and your family. How would it have been different? Could you think of ways to describe, I love what you said that Phil stopped listening. And, my father used to say, don't raise your voice, strengthen your argument. So, you argue your way out of it. And then, if no one's listening, Phil probably gave up. And when you stop listening and stop hearing, I think the entire relationship between providers and patients just disintegrates. But what are some of the things that you might point us to that would be ways to strengthen the system that would have supported you and Phil?
Okay. One thing that may have helped as we're sitting in the waiting room, maybe before we go into each appointment to see a new or an existing clinician that we'd seen before, would to have him fill out something. What are you here for today? What's your number one concern? I've seen those in some places, but this wasn't the case at the time I described. But like I said, he's not good at expressing things. Maybe even before the appointment, invite the patient to jot down things they wanted to discuss that day so that they're sure to bring those up and that you're sure to address them. And then another thing would be to find out what that number one concern is and address that first. I mean, Phil did need to wear his hearing aids. That would have helped. He did need treatment for his diabetes and his other conditions, but he was not going to listen to anything until they addressed what he was there for. And so I guess, not just listening, but giving evidence that you've listened, affirming them in some way.
Great, thank you. Just as a quick story to really springboard off of Joy's point, I facilitated a group of patients who have non-diabetic neuropathy pain. And I was doing this for a professor who's quite esteemed, a great researcher, well-funded, very compassionate physician who is beginning to understand, I will say, I think he'll agree, that he's beginning to understand the value of patients' voices in what really matters in encounters. And anyway, just quickly, he has a study that's going to compare 4 different drugs and which ones work best for this condition. And wanted to vet that with patients. And so, explained the whole study to patients and went through all the data that were going to be collected for this research study. And asked a really important, allowed me, I should say, to really frame an important question. And we said, what is it about your pain, your condition, your primary concern that you think is really most important here among these different drugs in this trial? And they said, you haven't asked the two things that matter the most to me: fatigue and sleep. I have pain that keeps me up. I disturb my partner. I sit in the lazy boy. Then I go to bed. Then I disturb them. Then they get up. I'm tired all the time. I feel like I'm going to fall asleep from the medications, from not having good sleep hygiene. And you're not even measuring that as a primary patient outcome with these 4 drugs. Luckily, we did this in time to include those measures along with the rest of the study, but it really underscores how when we listen to what's most important to Phil, how we listen to what Jonathan needs, how we hear that the new normal for Nick is throwing up in a basket for years, we need to turn the dialogue around a bit. And that power differential between our patients and that care they're receiving sometimes doesn't encourage that conversation. We have to almost force that conversation. And we all, I think, would prefer if it were a smoother and more collaborative conversation. So the center is known for its caring conversations. This underscores the importance of a caring conversation, I think. So thank you for sharing those. For those who help us shape messages around these experiences, we have 2 folks here sitting in the high chairs, I was going to call them, the big chairs, the chairs to my left. And I'd like to ask them also to introduce themselves briefly, but I'm going to ask Kathy if you would please speak to the point that I've raised about strategies for extracting and understanding patient experience in a way that brings more attention to the national discourse of the value of patient voice in health and healthcare services. What are ways that you bring that question to bear, and what are suggestions you have for growing an advocacy voice around patient experience?
Well, I'm Kathy Grossman. I'm a newspaper reporter. I work for Religion News Service. You can find me there, and I hope you will. Kathy.Grossman at religionnews.com. And the reason I'm pointing to that is because I'm the odd person here in many ways, but in 2 particular ways I'm the odd person because, thankfully, I'm not a person in chronic pain. Neither is anybody in my immediate family. I haven't had to be a direct caretaker for somebody in that situation. So I am on the outside. I'm in the general public, not a caretaker, not a patient, and not somebody who is in the profession directly of caring for people like this. And secondly, I'm a journalist. I'm not a health professional or an ethicist. So I tell stories for a living. And what I'm seeing, and I'm going to zero in particularly on the aspect of pain that we've been discussing today. There is a really uneven picture of pain out there. For example, I wrote up on there the word Zohydro. Have most of you heard of Zohydro? This is the big new, long-lasting opioid that is 5 times stronger than Vicodin. It's just been approved, and there are a lot of people who are incensed about this. And what you get is, for example, Dr. Oz and Dr. Sanjay Gupta get on TV, and the headline for this is Drug Abuse in America, the Lethal New Pill Hitting the Street. And in an offhand way, one of the doctors makes a slight reference to people who have, quote, legitimate pain. I think that would be you or you. But by and large, it is an entire 5-minute segment of lurid images of how the many ways are that this drug could be abused. And it has been approved in a form that does not have an abuse deterrent formulation. Now, that's a legitimate story, yes. However, what you have is constant coverage of the epidemic of abuse of opioids. And nobody is writing about a question I have, which is, why is there an epidemic of pain? You know, for those opioids to have been out there, they were originally out there before they were abused out there. They were out there because there were so many people in pain. Why are there so many people in pain right now? Are there more people in chronic pain now than there were 5 or 10 years ago? Or are we just more aware of it and more concerned and reporting it more? And why is there an unshakable in the public eye tie between the essential medications for pain management and pain relief and drug abusers? Why would the first question to Mr. Bell, have to, they're trying to sort out, is he there just trying to get some drugs? Instead of, is he there because he like his brother, is in acute pain? These questions are not really being addressed in the coverage. You don't hear voices of people who might use Zohydro because they have a legitimate need for it. There is a reason that that long-lasting drug was developed. Apparently there was felt that there was a need for that instead of people having to take a constant repetition of pills all day long. Perhaps it had to do with their ability to sleep and not have to get up and take pain pills all the time. I don't know why that would be seen as an improvement, but a lot of people, and enough people for the FDA to approve it, thought it was an important thing to have. So where are the voices of those people? Why aren't we finding about the legitimate uses of that? The people who have, as one of the doctors said, legitimate pain. So I think that there's a responsibility by the media to ask these kinds of questions. But to write these stories and to write the stories about real people who are facing these issues, we're going to need your help. We can't, there are privacy rules and good privacy rules, and I support privacy rules, but I can't tell someone's story if I can't use their name and I can't use their photograph. And I need help from you people to bring these stories forward. So be mindful of ways that you can tell the stories and encourage people to talk and be willing to talk with journalists about what's happening and what can be done.
Thank you. That's great advice for all of us. It is the challenge that we want to continue to speak about, and that is how do we bring these voices forward? Mugar, I'm going to ask you a question. We'll stick in the focus around pain just for a second. The Institute of Medicine's report calls for a cultural transformation to better prevent, assess, treat, and understand pain of all types. And so I'd like to ask you how journalism and storytelling, Kathy, you also, social media and other communication strategies can aid in this cultural transformation. Please introduce yourself.
Okay. Thank you, Kim. My name is Mugur Jana. I'm the director for the Center of Excellence in Health Communication to Underserved Populations from the University of Kansas. I'm also an associate professor at the School of Journalism and also at the Department of Family Medicine at KUMC. And, Kim, that's a really good question. And before answering, or trying to answer how journalists and social media and all other means of communication and channels that we have available can do a better job about telling us and informing the general public about pain, let's talk a little bit about the miserable job they're doing right now, okay? And I purposely use that term. And I really want to congratulate both Joy and Kathy for the wonderful job they're doing and for trying to put forward those personal stories that are so important. Last night, while I was thinking, what should I tell you today, I had an idea. I'm a researcher, and one of the things that I do is I'm trying to, as much as possible, to keep my colleagues from media accountable for the things that they're doing through my research. So I went to LexisNexis Academic and I said, okay, let's see how many stories about chronic pain were in newspaper articles, TV stories, news releases, or wires in the last year. Actually, and I have some data here. Again, the researcher in me needs data, okay? So there were over 400 stories, including the term chronic pain, that were released last year. Well, a year from yesterday. So what were those stories about? Well, the majority of them, over 80%, were just PR releases from pharmaceutical companies. They were about new drugs. They were about results from clinical trials. They were about great financial results by the pharmaceutical companies. So all the shareholders were really happy. A vast number of them addressed the concerns of abusing pain medicine. So Kathy, you were so right. but also some of them also talk about the difficulties for some of the patients to access pain medication in the current legislative environment. And I have some titles here, and you know, what you just said about the stereotyping of drug abusers or painkiller users by journalists and by communicators is so true. And I'll give you a couple of titles here. This was published on March 11 this year. It says, Pennsylvania doctors, painkillers can lead to heroin and substance abuse. Yeah. Other articles try to somehow create a link between the need for better pain treatment and the way that society, or better say, the health system, it's not doing the right thing for these patients. Like titles from September 2013, Opioid Refugees, Patients Adrift in Search of Pain Relief. These are very powerful things. And at the same time, very few of these articles do make a statement or try to address major issues that are happening in our society today in terms of how we treat our patients or how we make pain medication available to these patients. One specific article, and you may mention Zohydro, came into mind, and this was from April 4, 2014. It's called FDA HHS reaffirms support for chronic pain patients amid Zohydro ER debate. And the thing that I liked, and you know, we're tending to politicize this discussion a lot, unfortunately, was that they printed a quote from FDA Commissioner Dr. Margaret Hamburg. And she said that it's vitally important for the health and safety of all Americans that our expert professional regulators and healthcare officials in federal and state agencies are allowed to do their jobs without political interference from politicians who have neither medical nor scientific training. And very powerful, yes. Yeah. Well, I always continue looking to see what else is in these articles, in those over 400. Some of them focus on adverse effects of pain medications, but those only from the perspective of healthcare providers abusing treatments. So again, the old adage, if it bleeds, it leads, it seems that plays a very important role in the way journalists report about pain. Okay? Only a few of them, of these articles, highlight the important problem that chronic pain poses to society. There were a couple of press releases, you know, one by the American Pain Society in September of 2013, stating that more than 100 million Americans live with chronic pain. Another one from Rutgers University, talking about national statistics about pain. Unfortunately, none of these press releases that contain information that can show the general public how important this problem is made it to the mainstream media. They just died on the teleprompter. Joy, I was so impressed by your story. And I was so impressed because, in a way, I related to an experience that I personally have with my father, who suffered from chronic pain of malignant origin. And I was thinking that the thing that probably changed him more was not necessarily the pain and the resilience that he had to fight it, but the medication, you know. And once he started his opioid treatment, he was not the same anymore. And, you know, that personal angle, the human factor, unfortunately, is not reflected in media today. Of all 400 plus articles, only one mentioned the human factor. And when I took a closer look at that article, it turned out it was not an article. It was a book review. And this book review, it's called A Nation in Pain, Healing Our Biggest Health Problem by Judy Foreman. And this book showcasing her personal story. You know, pain, it's a really intimate, particular, and non-shareable experience. But we need to let people know about it. One of my recent research studies dealing with American Indians and their experience with diabetes. You know, we're talking about Americans, American Indians, we're thinking about really, really strong interfamily relations, you know? But what I found out through my research is that they live with diabetes, but they don't talk about it. A lot of people in their own family, a lot of people in their community don't know about diabetes. We provide them with a forum and the opportunity to openly talk about this. The response was phenomenal, not only from the community, but from other people who thought that their experiences are unique and what they were suffering because they were having diabetes was just them. And being able to combine these voices really, really make a change in the way the community per se started addressing diabetes. So in the end, I think I talked really more than I intended to. I think I strongly believe that a concentrated effort by all stakeholders, starting from the physicians and the patients, and ending with the CEO of the pharmaceutical company or the editor of the media outlet, should get together and reason and think about how can we bring the human factor forward. How can we bring these stories to the general public to showcase that those 100 million people living with chronic pain are really not alone, and they are really a force that needs to be reasoned with. Thank you.
I would love to give the panelists a chance to talk amongst themselves and ask each other questions as well as you, but I know we're running short on time. We could spend another day hearing from each of you. Is there I feel like it's a pregnant pause here. Somebody would love to jump in. Anybody? To ask what?
Well, I'll just say.
Sure.
The media, and as a patient and a journalist, there have been stories of chronic pain told just recently, front page stories in the Kansas City Star, and about people in pain, people like 60-year-old Gene Halbin of Bates County, Otis Reed of Baldwin City, Kansas. Both people who have such chronic pain, they're looking to move to Colorado because of the medical marijuana issue. But they tell their stories. Richard, I can see you laughing there. They tell their stories because there's a very clear result. This is what, if you pass a law, this is what's going to happen. What do you actually want to happen if you tell a story about chronic pain? What do you want ethicists and others here to happen? There's no clear narrative here other than to say how terrible it is that chronic pain happens. What do you want to occur? So there's no clear, other than to say how sad that is, for the media to actually follow. So that's what makes it harder. Also, there is it's not as visual. Nick Haines telling his story, I'm not missing any limbs here. I don't have any scars. It isn't a visual story in the same way as a lot of other conditions. And there isn't any clear course of action. You have the medical marijuana one. If the state of Missouri were to put on the ballot this year, in November, a referendum that allows for medical marijuana, people in chronic pain in this state would be able to do blank. Yes, that's a story, and they've been telling those stories. But there has to be a call for action to make it a clear call for action to make those stories worthwhile for the public, for the media to actually respond to.
Mostly agree with you. I mostly agree with you, but I'm going to disagree slightly. Yes, of course, if there's a clear call of action, that does help it move to the front page or move forward in the paper. However, I think that there is a trickling is a bad term. There's a broadening ripple of impact in helping the larger public understand something. I don't think until I got involved with the center and took a course with the center and so forth that I understood how many people are in chronic pain, but also the ripple effect it has. There's an economic story to be had. There's a business section story about the workplace impact of chronic pain. I mean, you know, you sound like a pretty productive and accomplished guy, but imagine if you weren't sick, you know, how much more energy you would have had for your job. And so there are opportunities to help the workforce that deals with people to understand people like Jonathan when you go to the hospital and your family and so forth, that they would never, it wouldn't be a situation where somebody's saying to you, and I wrote it down, if we had known who you are. I mean, that just makes me want to weep, because what if you hadn't been somebody famous? Then it didn't matter, you know? So they know who you are, but if your cousin, you mentioned 5 members of your family, if they don't know who they are, I'm sorry, but that's terrible. That is a story that I think can change a mindset in the larger population. Last point I wanted to get in while I still had the mic was to say, after 43 years in journalism, I doubt I've done as much actual direct good for people as your series did. Yeah, I think that was a real life changer for people.
But can I just say one other thing? You said you are not someone who has gone through chronic pain, and you have nobody in your family who's gone through chronic pain. As somebody who has gone through it, I mean, you just live with it. And it's even difficult to communicate to my wife. I mean, she's never, you know, she may have hurt a toe, she might have hurt a foot or something, never understands fully what you're actually going through. I mean, if you've never been through chronic pain, you can never understand how that changes your entire life. That is, you're totally absorbed in that. And so it's like being a functional alcoholic in a sense of being, how can you be so productive? You just do it. And you go through that pain all of your life.
Right. Well, can I say something too?
Yep.
Sure, go ahead, Jonathan.
Well, just adding on to what he just said, just like myself, okay, do I look like I'm on any drugs right now? Do I actually physically look like I am?
No.
Well, I take Oxycontin, I take ibuprofen, I take Percocet, all of these things. I took them at 5 o'clock this morning. But I'm functional. I'm able to do what I need to do, but it's in moderation. And like she was talking about the hydro, I don't know what that is, but Oxycontin has got such a bad name in the media now that they're even talking about taking it off the market. They've already changed the ingredient around that is not the same. And what that does is it affects people like myself that it actually helps because someone else out there misused it.
So question and a comment and a question. I think as a palliative care physician, I've been very disappointed in the media lately around the stories in chronic pain. I'm glad that you did that research, and none of what you said surprised me at all. The other story I heard recently was on NPR, 6-minute story about benzodiazepines and opiates being used together. I don't know who told it, but 5.5 minutes was, you take these 2 medicines together, you will die. And I prescribe, and the other palliative care physicians, to the benefit of the patient, those medications together all the time. And people need them. We know the risks. We help people manage the risks, understand the risks. So one of the untold stories is really how most of the time with good medical care, good health care teams, people with chronic pain can get good help, improve their function, improve their symptoms, and live better lives because of their interaction with the healthcare system. That doesn't bleed, so it doesn't lead. But why when they have these articles, why don't they spend 3 minutes talking about the good side and then the last 3 minutes talking about the bad side? I don't really know. The other untold story is that we can't fix people's moral compasses. And every 3 years, it's the new drug that people decide to either steal from their relative and take out on the street and sell for money. And that's just a dumb person and why they do it, what their motivation is, but we can't fix that. The other thing we can't fix is that People have addictive personalities that they inherit or develop, and they're at risk. And that's a rare, I mean, it's not that rare, but it's a different population. And to use the word legitimate pain, all pain is legitimate. What's illegitimate is people that abuse the healthcare system to either get rich or get high or do something stupid, and that can't get fixed. And they don't really, the media doesn't talk about how most of the time there isn't abuse and there is benefit. And then my question, which kind of relates to that, is to Nick. You, I think, were way too forgiving and what's the right word? Accepting of the inadequacy of the healthcare system to spend all that time, and you didn't tell us that you fired 4 doctors along the way for not listening to you and not responding to your legitimate complaints and getting you better help. I'm glad you're finally getting help now, but it should have happened a long time ago, so keep at it.
7 doctors, though.
It's always an honor for me to facilitate Patient Voice, so thank you very much. Panel, please join me in thanking them for their contribution.